Welcome to the Boomer Buzz, the show that focuses on issues of interest to the 60 and over crowd, both here on Long Island and across the country. Listen as experts keep you informed about the latest health solutions, financial options, and lifestyle choices, both for senior citizens and their families. Now, here are the hosts of the Boomer Buzz, Dr. Lamar Stanford and Patricia Stanford, corporate wellness consultant, on the voice of Nassau Community College, 90.3 WHPC.
Welcome to the Boomer Buzz, where each week we'll give you the buzz on how to stay healthy, wealthy, and wise after the age of 60.
Today, we're speaking with neurologist Dr. Stephen Tversky from the Winthrop Neuroscience Associates on the detection, treatment, and prevention of strokes.
Welcome to the show, Dr. Tversky. It's an honor to have such a knowledgeable authority on strokes. First of all, what technically is a stroke?
First of all, I just want to say thank you for having me here today, and I'm happy to be here and answer all your questions. A stroke, in layman terms, is just a blockage of blood flow to the brain, causing neurological problems. And there's a variety of different ways that this can happen. Majority of strokes, 85% of strokes, are due to a blood clot that occludes a blood vessel in the brain. And about 15% of strokes are due to bleeding or hemorrhage in the brain.
Okay. Now, maybe I could just clarify that. When you say occluded, that means it plugs the blood vessel.
Exactly.
Right, okay.
So, of all of the strokes, what is the most common in the 60 and over group?
So the most common is an ischemic stroke, where a blood clot either originates within the vessel or comes from somewhere else in the body and travels to the brain and occludes or blocks the blood vessel, obstructing blood flow to the brain. Okay.
And how would you know if you're having a stroke? What are the signs of stroke or a TIA?
Sure. So I like to say that every function of the brain, every part of the brain has its own function, and a clot can travel from anywhere in the body and travel to the brain, causing problems in any part of the brain. I like to use the analogy that a plane can fall from the ceiling, from the sky, and land anywhere on the ground, and it can cause quite a bit of damage if it's in an urban area, or it can cause very little damage if it's in a forest or in a rural area. Similar to the brain, there's parts of the brain that are very congested and have very important structures, and some parts of the brain that don't have as important structures. The American Heart Association uses the acronym called BFAST, B for balance, E for eyes, F for facial drooping, A for arm weakness, S for speech, and T for time. So any problems with your balance, your vision, your facial weakness, speech, arm weakness, leg weakness, those are all signs of a stroke.
How about a headache? Is that a big important indicator?
So headache is very nonspecific. Majority of strokes do not cause headaches. Less than 10% of strokes can cause headaches, only in particular parts of the brain.
If a person has migraine headaches, is that an indicator that maybe they've got some kind of problem neurologically?
Not necessarily a problem for stroke.
Okay.
Migraines can occur on their own. Migraines can mimic stroke. There's something called complicated migraine or migraine with aura that have transient neurological problems that can mimic a stroke. But there's no direct correlation with migraines and stroke.
So we wanted to give you an indication of how we met Dr. Tversky and how we know Dr. Tversky. So
maybe I should mention that.
Yeah.
Dr. Tversky treated me at the Winthrop Hospital when I recently suffered a stroke after open heart surgery. Now, how did you know that I'd suffered a stroke, since I didn't exhibit any classical symptoms of a stroke, like you talked about speech, walking, this type of thing? You were dead certain that I'd had a stroke. How did you know that?
Oh, that was easy. I had the imaging before I even saw you.
Okay.
So what kind of imaging was that?
When you came in with a CAT scan from a local radiology office, right, that already showed the stroke that you had. So I already, unfortunately, I already had the puzzle solved before I even saw you.
Maybe we should mention, which is really interesting, we couldn't take a MRI, that magnetic resonance
That's right.
test. And you were really kind of disappointed because you said that would have helped you a lot to do something.
That's right. An MRI is definitive for acute strokes. It will be positive in a matter of minutes and can stay positive for an acute stroke up to 10 to 14 days. And in your case, you had some recent open heart surgery, and it was just not safe enough to have a magnetic resonance imaging study because the magnet is so powerful and can affect the wires and coils that you have in your chest.
So would that be the procedure that's indicated if somebody comes to an emergency room and thinks that they're having a stroke? Would a CAT scan and an MRI be done immediately? Is that what would...
So an MRI, although it's a definitive test, it takes about an hour to do the procedure. Not everyone is a candidate for it because we're not sure if you have hardware, metal in your body. So when somebody arrives in the emergency room with signs of a stroke, we rely on our history, our physical exam, and we rely on a non-contrast CAT scan to tell us to make sure there's no bleeding in the brain. But a non-contrast CAT scan will not show an ischemic stroke immediately. It takes about 12 hours to see some changes on the CAT scan.
Okay. Now, they talk about, like a friend of mine had a stroke, and he didn't seem to have any kind of disability like I did, but he said they got him to the hospital, and during the first 3 hours, they worked on him. Now, why is that so crucial?
That's right. So when it comes to stroke, we have a crucial 3 hour, which can now be extended to 4.5 hours, where we can give clot-busting medication to try to dissolve the clot, whether it happens within the blood vessel wall or a clot travels from anywhere else in the body and goes to the brain. And now we have these clot-busting medication that can dissolve this clot. But as of now, it can only be given up to 4.5 hours from the last known well of when the patient was last seen well or when symptoms were witnessed.
Now, how did he know that he had a blockage rather than that bleeding, that aneurysm?
So I imagine your friend came to the emergency room, and the first thing they do is do a non-contrast CAT scan. And on a non-contrast CAT scan, blood would show up very bright. So they can exclude bleeding right away, and then they can treat him for an ischemic type stroke.
Okay, so that 3 hours really doesn't apply to the bleeding, the aneurysm type stroke then?
No, bleeding would be a contraindication to the clot-busting medication.
Oh, I see, okay. Now, we just need to take a quick break. You're listening to the Boomer Buzz on the voice of Nassau Community College, 90.3 WHPC. I'm Dr. Lamar Stanford, along with my wife, Patricia. She's a corporate wellness consultant. And our guest today is neurologist Dr. Stephen Tversky, talking about stroke detection, treatment, and prevention in the boomer population. Let's get back to some of the questions here. We were talking about prevention. How does a family history of stroke occurrence affect you as an individual?
There are certain genetic diseases that predispose you to stroke. Certain populations have a higher rate of intracranial vascular disease as opposed to extracranial vascular disease. So certainly a family history does play a role in that as well. I think just talking about populations as a whole, the Asian population, the Hispanic and African American population is much more likely to have atherosclerosis or plaque buildup in the medium, small vessels in the brain, whereas the European or the Caucasian population as a whole is more likely to have plaque buildup in large vessels such as the carotid artery. And that's where genetics plays a role.
Wow. So ethnicity has an impact on this thing.
Absolutely.
So when you see a person come into the emergency room, that may be a tell right there on ethnicity. I guess just a slight tell. But how about age? A person comes in, he's 50, he's 70, maybe 30. How does that work?
Right. So stroke is always thought of a disease of the elderly. The most common cause of stroke, which we'll get into a little bit later, is atrial fibrillation. And that's the most common cause of stroke after the age of 70. But stroke is possible in young children, in babies, in young adults, and the elderly. And there's different causes of stroke for each age group.
Is it that clot stroke or the ischemia bleeding stroke?
When I say stroke as a whole, I refer mostly to the ischemic type strokes, the clot that occludes the blood vessel. Yeah.
Mm-hmm. Now, talking about lifestyle prevention, suppose a person's a smoker. What are some of the problems that a person could get themselves into that would give them more predisposition towards a stroke?
Right. So, smoking is the number one modifiable risk factor for stroke. Things like obesity and smoking play a role. It accelerates atherosclerosis or plaque buildup in your blood vessels, and puts you at a higher risk for stroke in the future. So, smoking is the number one modifiable risk factor, followed by obesity.
Okay.
What about diet?
Right. So with obesity comes diet, exercise. Those are things that are modifiable and prevent stroke. Absolutely.
So what should a person be staying away from as far as foods are concerned?
Right. So
certain types of foods.
The American Heart Association still recommends a Mediterranean diet. Lots of greens, fish, lean meats, salads. Staying away from too many carbs, pasta. I know right now there's a big fad, the ketogenic diet fad, and there just hasn't been much research with ketogenic diets and stroke that I'm aware of as of now. But I think that's something to be studied.
So the jury's still out on that ketogenic.
That's right.
You're right. Yeah. Now we talked about smoking being a big problem. How about alcohol?
Alcohol puts you in a higher risk for the bleeding type stroke, the hemorrhage. The intracerebral hemorrhage, the hemorrhagic type strokes, just because it makes the vessel walls a little bit more friable, more weaker, and predisposes you to bleeding.
Wow.
Yeah.
Okay.
Does exercise help to prevent in stroke prevention?
Absolutely. So the American Heart Association recommends at least 30 minutes of exercise 3 times a week, and there have been studies showing that if you can get your heart rate up high enough where you can break a sweat and maintain that for 30 minutes 3 times a day, that will prevent a stroke. Could prevent a stroke.
Right, yeah. The the bleeding type stroke, is one more severe than the other?
So when we talk about intracerebral hemorrhage, we talk about hemorrhage. There's different types. There's subdural hemorrhages, the bleeding between the surface of the brain and the skull. We talk about bleeding within the brain tissue itself, intracerebral hemorrhage. And there's also subarachnoid hemorrhage, which is most commonly due to ruptured aneurysms. They're all dangerous in their own sense. The theory is the more blood you have in the brain, the worse it is, because blood doesn't belong in the brain. There's a blood-brain barrier for a reason. So the more blood that enters the brain, the more compression and more swelling that it causes on the healthy brain tissue, and can be lethal.
So you come into the emergency room and somebody says, Dr. Tversky, this person's had a bleeding stroke. Mm-hmm. Is that more severe than if he had the clot stroke? Again, you're saying it depends, huh?
Right. So the ischemic type strokes can affect very small vessels, large vessels. There's different types. There's different degrees of severity when it comes to ischemic type stroke, as well as intracerebral hemorrhage. You could have a very small, less than 1 millimeter hemorrhage, which may not be all that significant if it's in a certain part of the brain, or you can have a large 100 milliliter hemorrhage in the brain. So there's variations to each.
And people can die of either one of those strokes.
Absolutely.
First time, bang.
The highest risk of death is with the intracerebral hemorrhage.
Wow.
I'm Patricia Stanford, corporate wellness consultant, along with my husband today, Dr. Lamar Stanford. Not my husband today, my husband forever.
Thank you.
And our guest today is neurologist Dr. Stephen Tversky, talking about stroke detection, treatment, and prevention in the boomer population. You're listening to the Boomer Buzz on the voice of Nassau Community College. 90.3 WHPC.
Which of these items would you want to consume on a daily basis? Antifreeze, floor wax, or house paint?
You're kidding, right?
They're
toxic. It's something that humans should not be eating or drinking.
The truth is, 62% of medications purchased online are fake, and many contain these harmful ingredients.
So these are just frauds.
Pretty dirty trick to play on somebody. You're taking their money and giving them this.
I want to take medication to stay healthy, not make me a lot sicker.
And what do you think about this item?
That is a big bowl of nothing.
Many rogue sites sell prescriptions with little to no medication at all. The good news is you can find legitimate online pharmacies by looking for .pharmacy in a website's address.
So if I see .pharmacy,
It's legit.
Visit safe.pharmacy to learn how you and your loved ones can be certain the medications you buy online are safe. A public service from the National Association of Boards of Pharmacy.
Welcome back to the Boomer Buzz on the voice of NASA Community College, 90.3 WHPC. I'm Dr. Lamar Stanford, along with my wife, Patricia, happens to be a wellness consultant. And our guest today is Dr. Stephen Tversky, a neurologist, and he's talking about stroke prevention, treatment, and detection, I should say, in the boomer population. Now, before the break, we talked about prevention of a stroke. What if you've suffered a stroke? How do you treat a stroke victim? I guess that depends, doesn't it?
Absolutely. I think that the critical time window that we have is in the first 24 hours, I'd say. I think if somebody comes in with the symptoms of a stroke, with an ischemic stroke, where the clot occludes a blood vessel in the brain, we can treat it in the first up to 4.5 hours with clot-busting medication called TPA. If the stroke is severe, it blocks a large vessel in the brain or the carotid artery. We have now up to a 24-hour window where we go in with a catheter device and try to retrieve or suck out that clot and restore blood flow. So the first 24 hours are absolutely critical to a stroke. Following the first 24 hours, there's very little we can do acutely. The stroke has already set in. There's already some degree of damage to the brain, and at that point we focus on two things. We focus on physical therapy, speech therapy if necessary, occupational therapy if necessary. All those things to try to just improve your outcome overall. And the most amount of recovery occurs in the first 3 months. So those first few days, weeks, months are absolutely crucial to a stroke recovery.
Now, if I can talk a little personally about my situation, when I had my stroke, there was some mention that so many days after the occurrence, you kept me in the hospital watching that this didn't occur. Can you just maybe clarify that a little bit? It seemed to be important that I...
Sure.
Yeah.
I think you had a very unique type of stroke where it affected your cerebellum, the balance center of the brain. And because of the area of the stroke... there's very little space in the back of the brain. If you imagine, this is where your skull starts to taper off, and it's a very tight area of very important structures. And there's much less space than there is in the front of your skull, up top by your forehead. And for that reason, we after you have a stroke, there's a period where you get some swelling. In the first 3 to 5 days, you get swelling surrounding the area of the stroke, and that swelling can compress healthy brain tissue, and in some cases can cause a backup of fluid, and that fluid can cause even more compression and swelling in the brain, and can actually be fatal in some cases. So this is why we kept you in the hospital for several days to watch you closely, make sure your stroke didn't progress, the swelling didn't progress, and didn't cause more problems.
Yeah, because I felt great, and you were keeping me in the hospital there, and I was getting a little impatient, wasn't I?
Absolutely.
But anyway... talking again about those two types of stroke, is surgery ever a treatment as an option in strokes? You talked about putting catheters and things up there. Maybe you can just tell us a little bit about using hardware in that area.
That's right. So similar to a cardiac cath, or you could put in a wire into the groin or the radial artery, and you could feed that wire all the way up to the brain. And we have now special devices, stent retriever devices, where we can go in and try to remove a clot, either pull it out or suck it out with a vacuum-type catheter, and try to restore as much blood flow to the brain as possible. So the surgery is limited now to interventional neuroradiology or interventional neurosurgery. In some cases, if there's an aneurysm that had ruptured and you have a subarachnoid hemorrhage, we can go in in a similar fashion with a catheter. We can go in and put some wires or coils in the aneurysm to stop the bleeding. But sometimes open neurosurgery and open the brain and do surgery is indicated as well.
Now, this is a technical question. When I had open heart surgery, there was a surgeon who worked on me, and I already had a cardiologist who didn't do surgery. Now, in your situation, you're a neurologist. Now, do you do everything? Do you do surgery, the whole bit, or do you leave that to specialists?
That's right. So we have specialists that I work with. I'm a vascular neurologist. I specialize in stroke, but I'm not an interventional vascular neurologist. So we leave that to the specialists.
So you wouldn't be in the operating room 2 or 3 times a week type situation?
No, I'd be assisting. I'd be calling them on the phone and say, this is a good patient to take to the operating room. And I'd be in there maybe giving them advice or just talking through certain cases. But I would not be in the operating room doing the procedure myself.
You're listening to the Boomer Buzz on the voice of Nassau Community College, 90.3. And our guest today is neurologist Dr. Stephen Tversky, talking about stroke detection, treatment, and prevention in the boomer population. So, Dr. Tversky, are men more likely to have strokes than women are?
Yes. Short answer is yes.
Okay.
For a number of reasons. And I think lifestyle is the number one cause. I think men are much more likely to be non-compliant with their medication than women.
I was going to say exactly that. I think women are better patients overall than men are.
There's actually, I think there was a study done that showed that men who are not married are actually more likely to have a stroke than men who are married. The reason is because they have somebody watching what they eat and picking at their bad habits.
Tell me. He's taking care of me after these things like a nurse.
That's a good one. Okay. Well, then I guess you'll appreciate me more, Lamar.
Yes.
In this study of strokes advancing rapidly these days, or are there rapid advancements every year in the treatment of strokes?
Absolutely. I think without a doubt, I think vascular neurology, stroke is one of the most evolving fields of medicine. Without question. I think just these procedures that I mentioned earlier, these interventional devices where we can go in and remove a clot, have revolutionized stroke. I think only in 2015 did they come out with five trials that showed that this form of treatment was effective and it revolutionized stroke as a whole. I think now we have new devices that are much more safer. We have new guidelines. We also extended the window for treatment of strokes up to 24 hours. Previously, it was 6 hours. And now we're also giving this clot-busting medication much more readily, more frequently. We extended the window from 3 to 4.5 hours. Mm-hmm. There was recent trials this year. There were 2 trials that looked at extending it up to 9 hours in the right circumstance. So I think this is a very fast-moving field. It's evolving. I think stroke used to be the third highest cause of mortality in the world, and now it's going down to number 5.
That's wonderful. And also, I think that my mother had a stroke at age 25 when she was pregnant with me. And I don't think very much was done for her at all. That was in 1952. So she was taken to the hospital. I'm not sure if they did anything except let her rest in the hospital. And she is still paralyzed. She's still alive. She's paralyzed on her left side, partially paralyzed in her leg. Her arm is completely paralyzed. She did not speak after the stroke, and they did manage to get some of her speech back. But she talked about rehab in those days, and it was an awful experience. Let's just put it that way. They would take her paralyzed arm and put it in buckets of ice to try to bring the arm back. So I know that in my lifetime, certainly things have changed. What about pharmaceuticals? Is there anything else on the horizon other than that the pharmaceutical that would be given to stroke victims right after the stroke?
Sure. In the acute stroke phase, I think other than this clot-busting medication, the TPA, there's one new medication that's out on the market called tenactoplas, but they work very similarly to each other, and there's not much else on the horizon that I can see. There have been some new medications in the last 5 or 6 years for after-stroke treatment. The medication for patients that have irregular heart rhythm, such as atrial fibrillation, that were previously on Coumadin or warfarin for a very long time, which is a very difficult medication to take, requires lots of monitoring. They have a new class of medication now, which is much more easier to take, more tolerable, doesn't require testing, laboratory testing, and it also help prevent stroke in that elder population that has atrial fibrillation.
So are they basically blood thinners?
Exactly. That's exactly what I'm talking about, yes.
Okay.
New group of blood thinners.
Okay. And what about afterward? Do you see that most of your patients are able to regain a certain amount of independence after a stroke?
Again, that's a hard question to answer because every stroke is sort of unique. It all depends which area of the body is affected, what symptoms brought you to the hospital. Whether it's the most there's what we call disabling symptoms and non-disabling symptoms. You can have symptoms of some numbness, tingling in your face and arm, and that can recover fairly well. Or you can have somebody who's severely disabled from speech and an inability to speak, can't swallow, can't eat, paralyzed on one side of their body. So I think the degree of recovery depends on the initial size of the stroke, and of course their age also plays a role as well.
Mm-hmm.
Let me intervene here and try and get a little bit of free medical advice from my doctor. I had that stroke. I don't seem to have any disability, maybe a slight balance issue. What are my chances of staying free of disability for an extended period of time?
I think you recovered amazingly well. I was shocked at how well you had recovered and how quickly you recovered. You had almost no symptoms of the stroke when I saw you, and I think that should stay that way because you had already recovered from your symptoms by the time that I had seen you. And
it probably helped that I wasn't into alcohol or obesity or smoking or stuff like that. Yeah.
So, Dr. Tversky, how do we get in touch with you? How does our listening audience get in touch with you if they want to know more about stroke prevention or they need to see a neurologist?
Sure. I'm happy to share my contact information. I work for NYU Winthrop Neuroscience Associates. We can be reached at 516-663-4525.
Okay.
Excellent. So thank you so much.
Yeah, we want to thank our guest, neurologist Dr. Stephen Tversky, for joining us today. This discussion has been so interesting and informative. In fact, can we get you to come back again and maybe discuss some other crucial neurological issues like Parkinson's disease, Alzheimer's, for our boomer audience?
Absolutely.
Excellent.
I'd be happy.
Thank you so much. I'm Dr. Lamar Stanford, along with my wife Patricia Stanford. The show will be available as a podcast on iTunes, Android, Podcasts, Spotify, and Spreaker.com. If you have any comments, email them to us anytime at whpc@ncc.edu. Thank you for listening to the Boomer Buzz here on the voice of NASA Community College 90.3.